Hi, everybody. I hope you can hear me okay. So this morning in our department, we had a lovely talk about this particular X-ray. Unfortunately, I forgot to record it, thinking I had recorded it. And it turns out I just had the Zoom meeting open, but wasn't recording it. So unfortunately, that means you're going to get the dry version with just me talking. And we had a wonderful session this morning. I'm so sorry that you're going to miss out on the laughs that we had and the interesting questions and things like that. But I'll try and do my best to at least cover all the things that we did talk about. And also just to give the pertinent points and go through everything that was asked and things like that. So what we had was a referral from a local hospital, one of our district referral hospitals. Then they actually sent through the picture of this patient who had come in with a stab on the right side, had been sent for x-rays after suturing, and had then deteriorated while in x-ray. At the hospital, there was just one radiographer at night, quite a few patients. Patient was waiting for quite some time, and then slowly but surely got worse and worse. And the radiographer had to rush the patient back to the emergency area. And when they put the patient back on, they found SATs were extremely low. He was having very low BPs. He was encephalopathic and things like that. So the one thing that you can see from the X-ray, and it's quite an obvious one, is that we've got a just try and get a better, there we go. Let's try and get the laser pointer going, hopefully, if I can. I don't know if I'll be able to, there we go. All right. So here we go. So here you can see the outline of the lung. So this is a nice obvious pneumothorax. And we can see when we follow the lung markings, they're extremely dense because the lung has collapsed. And then you suddenly get to nothing over there. Now, this is a tension pneumothorax. And what we mean by tension pneumothorax is that there's nowhere for the air to escape. So basically tension builds up within the thoracic cavity. So the thing is with this patient, unfortunately, when he was sutured, prior to his x-ray, that's actually when the problem started. So in speaking to the doctor after that, the patient had actually had a bubbling wound. He could hear a bit of air moving in and out, but it's a common mistake. It's not something unheard of. The patient had a stab just somewhere around here, and the patient was sutured initially, and that turned a simple pneumothorax into a tension pneumothorax. And another way to tell from this x-ray, you can see the trachea is deviated here. You can see the carina is right out, and in fact how the bronchi are actually pushed flat, and the cardiac shadow is pushed, and things like that. So that's how you can tell also. And clinically, you'd see a deviation of your trachea away from the side of the pneumothorax. So your trachea would move in this direction. If your pneumothorax, tension pneumothorax was on this side, it would move in the opposite direction. So they phoned because they weren't sure what to do. They wanted to actually start the patient on inotropes and put in an IC drain, and they were getting ready for that. And of course, the first thing that needs to be done in a case like this is that you need to actually put in a chest needle thoracostomy, which is a needle penetration into that second intercostal space. So you use a green, if worse comes to worse, or an orange IV cannula or Jalco, and you go in at 90 degrees to the chest. You go through the second intercostal space in the mid-clavicular line. So just about there, and that's when you try and get it in. And you should hear a gush of air. Now, one of the things that we discussed this morning is that actually the newer teachings that you should go somewhere towards the fifth intercostal space on the lateral side, because they've actually found much better results. However, don't do that yet. It hasn't become commonplace teaching, but in the next year or two, we might well find a lot of articles discussing that. And we may well see that, patients, or that they're actually advocating for this type of intervention. Yeah. So that's one of the things that may come out from this. So, so that was the first thing that they should have done. right, which they did do. And luckily, the patient did start to improve after that. But the question is, why was the patient deteriorating? It may sound simple, but we did go through it this morning, and we kind of came to an answer. So when this patient has a new tension pneumothorax, which organ is giving you the most problems is not actually the lungs. It's not the lung that we are worried about. Yes, the patient is hypoventilated. There is a VQ mismatch and things like that. But the main thing is actually the heart. And what's happening is that you are starting to get compression of the heart, basically an air tamponade. Because what's happening is you're getting pressure on the heart from this side and this side. Now, as I was telling them this morning, I'm not 100% sure on how to turn this arrow around. So I'm just to it from the side. But you've got pressure going in this direction, all right? So it's not the direction of the arrow. Think of it in the opposite direction. So you've got this heart that's getting squeezed, exactly like what would happen if you had a tamponade of fluid or blood and things like this. At this time, it's the lung and air and things like that. So what's happening is you've got your superior vena cava that's draining into your right atrium and your right ventricle. So what happens is that every time you take a breath, blood is moved up that column of the SVC, IVC into the SVC. And then every time the right ventricle expands, it again creates a vacuum effect to pull blood into the right atrium. And then that blood is then passed along through the pulmonary vessels, and then it passes in through the left ventricle. So what happens is that if your right ventricle can't expand, it's unable to pull enough blood in. So as we know from Starling's law, the less you expand, the less you stretch, the less you can contract. So what happens is less blood is then passed along through the pulmonary vessels. And then the left atrium, left ventricle also has a slight suction effect when it expands, but now there's less blood to pull in, and there's less ability of it to expand. So you have less blood being pulled into the left ventricle, and that's being circulated around the body. So with the first beat, less blood is passed into the right ventricle. So less blood goes through to the lungs, less blood goes through the left ventricle, less blood goes through the body. So on your next beat, you have even less blood going to your right ventricle, and then to your left ventricle, and even less going through to the circulation. So, and it continues in the spiral downwards and downwards and downwards until the patient basically goes into cardiac arrest. So as soon as you do the needle thoracostomy, you then relieve this, because now there's a lot of pressure that's taken out. That pressure that was being created by this air pocket over here is now relieved. So everything has a chance to move back to its original position. And this allows you to get the patient's cardiac function going well again. And that's what the patient actually had. Once they did the needle thoracostomy, they heard the rush of air, patient started to improve, BP started to go up, the patient started feeling better, SATs went up, everything did improve, but he still wasn't doing too well. So they did have to put an intercostal drain in. So one of the questions that was asked was, okay, do we always put an intercostal drain in before we do an X-ray? And the answer is no. If you've got a very obvious pneumothorax, or at least my thinking on it, if you've got a bubbling wound, a wound that's sucking air, things like that, then I would normally put in the IC drain before sending the patient off to the X-ray. Now, if you see a single bubble, I mean, that could just be from your bethadine or something, or your cleaning solution. But if you see regular bubbles and, the wound is, bubbling, but if you're still not 100% sure, at least don't suture the wound. Because once the patient leaves your emergency department, they're no longer within your control. Unless you send the patient accompanied and you want the X-ray done urgently, that's a different story. But let's be honest, in most of our emergency departments, we don't have staff to spare to go up with every patient who's got a stabbed chest, we just see too many of them, So my advice would be probably just, allow the patient to go without being sutured. And when the patient comes back, hopefully the patient will be seen by somebody else. No, I'm just kidding. What I mean is then you can tell for sure whether there's a hemopneumo and things like that, and then proceed with your IC drain insertion, and you can take it from there. So that was one of the questions. And one of the other questions was very good as well. How do we, what do we do if the stab wound is where we want to put in the IC drain? And the remarks that were made were basically, if the assailant looked at the victim and said, well, I'm going to stab them in the fourth intercostal space, in the mid axillary line, and I'm going to make sure that I create a wound that's large enough for an IC drain to penetrate so that they can easily save this person after I stab them, then by all means go for it. But basically what you mean is that if you are lucky enough to have an area that's open and you can put a drain through it, by all means use it. But make sure the area is clean, you've done a good finger sweep, you make sure there's nothing else. But I would say 99.9% of the time, either go one level above, or if it's quite high, then go one level below and just leave that wound alone. We don't know what contaminants may be in that wound. So ideally, you don't want to. If you're very lucky, the assailant used a scalpel and went in exactly where you would have put in your IC drain, and then by all means do it, but otherwise, no. Then the other question that came was, all right, what happens if we've got a large sucking wound? So we took the example of a large cut, let's say, over there, and the air is now being, you can hear you can just see this big sucking wound. So what's the problem with the sucking wound? So what happens is that every time the patient breathes in, air is escaping from here, that's for sure. But every time the patient breathes out, air is escaping. But every time the patient breathes in, that air is being pulled back in. So you start getting a situation similar to a tension pneumothorax, but also you get very poor ventilation because all of that air is just escaping out of this area, and you're creating a slight tension effect as well. So and your lung starts to collapse quite quickly. So the thing that you need to do is that you actually need to put in a three-way valve. So what we do for these patients, I'm going to try and do it as best as I can, is that you take anything non-adhesive, anything, whatever you can find that's sterile and non-adhesive, and you place it over the wound. So in the ACLS course and the HLS course, they advise you to use your credit card. Please don't use your credit card unless you're on the side of the road. I think the ACLS just wants your credit card info. So you would place something over there, and then what you would do is then you would place adhesives along the adhesives along the three sides. So what you would get is something that looks like this with one free end that's open. So it creates a valve effect. So what happens every time the patient breathes out, so air is now released from the lung, that air is able to escape via this valve. But as soon as the patient breathes in, the flap closes. So there's no air being pulled in again. So you're removing that tension effect. So of course, if you have something like this, you would then put in the IC drain. And as I told them, there's no harm in people working concurrently. So if you have a wound like this, it's quite serious. Somebody puts in the IC drain, somebody goes ahead and sutures the wound at the same time. Now, of course, if you're worried about your precordial stabs and your heart and things like that, you would do ultrasounds and all that. But at that time, the most pressing thing would be that wound that's there. So that more or less covers how you would manage tension pneumothorax and the pathophysiology behind it. There was one other interesting thing that we had looked at, which I'll just get to now. Let me just bring it up for you here. Okay, so the patient actually had quite a deranged, quite a deranged ABG. So I was just showing them the ABG assistant that we've got on the website so that you guys can try and use it. So, just sometimes, maybe you're not 100% sure of what's going on and things like that. So under the calculators, we do have an arterial and ABG assistant, all right? So this particular patient that we had, when they did give me his results, it was 6.98 for the pH. His PaCO2 had started to go up quite a bit, so it was 11. His bicarb was still about 21. The only thing we don't have on here is the lactate. What am I doing here? His lactate was actually quite high as well. Let me just get this back up to where it was. Sorry about that. It's just using the slider on my mouse. The PaO2, I can't remember, so we're just going to use that. FiO2, I can't remember, so we're just going to use that. Apologies for that. It's just a knock at my office door. All right, so we don't have that. So then we can just go ahead and analyze this. And we can see that what we have is a respiratory acidosis. compensatory metabolic compensation. Possible causes include hypoventilation, which is the case in this patient, and it just gives us some examples. So it could be sedatives, airway obstruction, acute exacerbation of COPD. So it's just a little tool that you guys can use, and in his case, we could, like I say, the lactates were quite high. They had gone up to, I can't remember, but it was quite a high number. So, the patient was in quite a bit of distress. He did come to Madadeni after that, and he was treated over a few days. And he actually did quite well. So, I hope that's something that you guys will learn from, and hopefully I will remember to make sure the recording is on the next time, because we had some lovely questions after that. So, yes, one of the other things that we had talked about was autotransfusion in terms of hemothorax, and there was quite a bit that we got into. But basically, what the basic gist of it was, you auto-transfuse the patient for two reasons. Number one, you fear the patient is going to become anemic, and you have to have the facilities, of course. You need to have the correct type of ICD drain, particularly, I think, the one that we get from Senapi that we're using in KZN at the moment. Some of you may have used a similar thing in your hospitals, whether you're overseas or in South Africa. Of course, if you're using the very old IC drain bottles, they're not compatible with auto-transfusion, but most hospitals have moved away from doing those unless you're in a very rural area. And of course, budgets and things like that. The newer IC drain bottles are quite expensive. I just want to see if I can bring up a picture of the new ones, just so that we could have a look and see. Just get this here. Just going to try and get it on Google in the meantime. See if I can just show it to you guys just for the purpose of this. If they bring up something, hopefully it does. It doesn't really seem to be doing it at the moment. So unfortunately, I'll just have to move away from that. Okay, I think it's just my internet connection as well. So anyway, like we had said, so if the patient is in danger of anemia and its symptoms, or if the patient needs a thoracotomy, and if it's in the case of a trauma, normally number one leads to number two. So if your patient is bleeding so much that they become anemic, then chances are they're going to need a thoracotomy to stop the bleeding. If, for example, your patient, with hemothorax, we've also got to observe the patient. So if they're bleeding more than 200 mils per hour, 250 mils per hour for 4 hours, then we know that they need a thoracotomy. So what happens if you're observing? Then in those cases, if you don't auto-transfuse, it's not the end of the world. It's not to say every patient must be auto-transfused. It's just beneficial. It's better. It's cost-saving. However, instead of putting a patient, because there are some risks involved, you are putting heparin, even though it's not a large amount, you are using a bit of heparin in there. And, you might, if you get the dosages wrong, or, you give a bolus by mistake, you could accidentally cause a bleeding diathesis and things like that. So, bleeding disorder. So, you've got to really weigh up the pros and cons of it. But if you suspect your patient needs a thoracotomy, they're bleeding that much, then definitely do an autotransfusion. If you're not sure and you wait, if worst comes to us, a patient will receive emergency blood or blood transfusions later on and things like that. I don't think anybody's going to get mad at you as a junior doctor if you waited to see and didn't autotransfuse. They may get cross if you could see that there was immediately a lot of bleeding and you didn't autotransfuse. You do have a little bit of time, so you can always make that decision. If you're not 100% sure, always remember to ask. So anyway, that was just an interesting x-ray that we went through. I hope you guys enjoyed it as well. And my apologies, I will remember to press the record button so the next time you can hear all the wonderful people from our emergency department asking their questions and the laughs that we have during the meetings. Okay, thanks. Keep well. Bye.